Hello everyone, so now we have addressed how to manage bileaflet disease using fairly straightforward techniques. Sometimes the valves are just a little bit more complicated and they need to really be addressed by decreasing posterior leaflet height. As we know from the history of mitral valve repair, sometimes the very best solution is actually to do a more aggressive resection and what's called a sliding valvuloplasty. So we're going to approach that robotically. Let's take a look. Now, we've discussed ways of managing bileaflet disease or complex pathology with conservative first approaches. This is a case where you have a very tall anterior leaflet, a acute intermitral angle, and this is a situation where we might need to do more than we've previously demonstrated. The atriotomy is performed. Initial valve analysis reveals diffuse posterior leaflet pathology. You can see the significant jet lesion to the upper left of your screen. And upon inspection, it's diffuse myxomatous disease. While bileaflet, it's largely posterior. And in sort of Carpentier type of nomenclature, this would be called form fruste due to the diffuse nature of the posterior anatomy. And so in this case, given the tall anterior leaflet, while other techniques could be utilized as we previously just demonstrated in this season, a sliding valvuloplasty is utilized, but not in the traditional quadrangular sense, but by starting with a triangular resection and then simply undermining the leaflet and debulking the excess tissue, dividing the secondary and tertiary cords along the way, and then performing the sliding valvuloplasty. We tend to prefer, again, interrupted figure of 8 monofilament sutures, as this allows us to stepwise not only perform intracorporeal tying of these sutures, but also adapt to the anatomy to deem what is necessary. Again, the slide is occurred by bringing the existing leaflet tissue along the annulus, thereby reducing the height. Now we still can do some extra trimming of the leaflet once the two leaflet portions are back together, and now do the completion valvuloplasty using the same interrupted techniques previously demonstrated. A 38 millimeter band is then implanted, and excellent coaptation can be identified. We had also divided a small cord in the anterior leaflet in this case. Further demonstrating this similarly, another case where there's a tall anterior leaflet that's touching the outflow tract septum, acute mitral angle, and diffuse posterior leaflet disease. Cross clamp was applied, and valve analysis begun. One can see that there is, again, diffuse posterior degeneration. The anterior leaflet is reasonable. But given the diffuse nature, resection is decided. Initial triangular resection is performed. You can see that this little middle segment is likely going to have to go as well. But we can see some fairly robust secondary and perhaps even tertiary fan cords that I've decided to divide for later, and then undermining this tissue until we have good supported leaflet. As you can see, there's a cord group on the P1 side, and then undermining all the way to P3, You can see there's a little MAC or microlinear calcification there at the base of P3, which we're going to avoid. And then bringing these two leaflets together while navigating that MAC. But the key thing is to making sure that that aligns quite nicely. This is another nice demonstration of those retraction sutures being placed when more complex resection is required or even assessment is required. So the valvuloplasty is performed to the annulus, or at least to the hinge point, creating height reduction. And again, marching that P3 and edge of P2 leaflet closer to the midline. Which in effect does reduce the posterior leaflet height quite substantially. Again, small bite on the leaflet side, larger bite on the annular side in order to get that height reduction and the effective slide. Now, this can appear daunting, but the truth is, these cases, as long as we follow the anatomy and follow lesion-specific therapy, and you're building upon your skill set, this is something that's very doable. With good restoration, somewhat plastic surgery of the mitral per se. As long as there's not tension, one can project durability. But when there is tension on any of the leaflet areas, be it the anastomotic area, be it at the hinge point or annulus, that's when long-term failures might occur. So part of the mandate we must always follow is tension freedom. Because then we exchange the pathology of excess motion for restricted motion, which can have consequences down the road. As long as the leaflet mobility is preserved, one can expect normal physiologic function and durability. You can already see the leaflet is starting to behave normally at this point. And even without the valvular anastomosis, we have a relative state of competence. But we still have work to do. So now we are going to further reduce the posterior leaflet height just a little bit by doing an ipsilateral chordal transfer using these robust secondary and tertiary fan cords. And by so doing, this not only reduces the height, but actually preserves the posterior leaflet motion given the native chordal use. Which are, of course, under native tension and not artificial tension. The leading edge anastomosis is reapproximated. This is substantiated by another edge suture, which is usually a simple stitch. And then again, using the fingers approach of the dual blade retractor, this presents the valvular tissue to allow the remainder of the valvuloplasty to be done fairly easily. Again, the leaflet tissue to leaflet tissue aligned and not a bulky type of anastomosis is important for a smooth coaptation surface. Once again, demonstrating dividing one limb of the previous stitch, keeping the other limb to allow it to stretch, and then removing all excess suture material, which is very easy to do with the robot. And then a final test. And we can see that we've got good ratio of the anterior to posterior, the 2/3 to 1/3 ratio, and good depth of coaptation. And so at this juncture, we'll divide a couple of extra secondary chords just to further augment that coaptation, much like we've demonstrated previously. Mainly at the restriction point, which you can visualize during testing. And then again, another 38 millimeter band to complete the repair. So now we've seen how to do sliding valvuloplasty for complex mitral valve disease. Now sometimes mitral valve regurgitation presents with other problems. Join us in our next episode. We're going to approach this doing multiple concomitant procedures in conjunction with mitral valve repair.